Welcome back to Your Health radio and television program. I am Dr. David Morwood. I am a board-certified plastic surgeon, and I am so pleased and honored to have as my guest Dr. William Reed, heart surgeon, cardiothoracic surgeon, more commonly or affectionately known as Bill, to those of us who are lucky enough to work with him. Dr. Reed, you know, before we go on and talk about valve surgery, one of the things I want to mention is, as I said to Dr. DeSario before, I seem to find myself in the emergency room or hospital a fair amount as a plastic surgeon taking care of emergencies. And you seem to be one of the hardest working surgeons, doctors I've ever met. And to do cardiac surgery, it's not really like a part-time occupation, is it? I mean, you guys work hard, don't you think?
Right, and you have to take, it's not just the operation itself. I believe very strongly that it's the intensive care unit management afterwards. It's the making sure that any complications that develop get taken care of quickly so that they don't develop into major problems like atrial fibrillation or irregular heartbeats. Patients that have difficulty breathing, you don't want to let them get too far, get into a situation where they develop pneumonia, because then a lot of bad things can happen to people.
Well, Dr. Reed, I appreciate that very much. And later on in the segment, I do want to talk about some of the hours that you've put into the training and what it's like, and et cetera. But I want to know something about valve surgery. It seems that you guys have gotten really good at doing vessel surgery, and I know, there's data that not only can you relieve angina, but I think you actually can extend people's lives, I think,
certainly,
right, with this
yeah.
bypass or vessel surgery for the heart. Now let's start with teaching the audience about the chambers of the heart, right? There's ventricles, there's a right and left ventricle, and then there's also the atriums, right?
Right.
Now, they're separated by valves, isn't that correct?
That's correct.
Now, the valves prevent the blood from sort of going backwards. It makes the blood go in a unidirectional flow. Is that right?
That's correct, right.
So why would you ever need to operate on a valve?
Well, what happens is that there are some diseases or illnesses that cause valves to fail. I was in Alaska for 8 years where there was a large population of people that had been exposed to and developed rheumatic fever 30 or 40 years ago. And rheumatic fever causes the valves to wither and scar down. And what we were seeing in that population, and this was mostly natives, but it was basically anybody that had been up there at the time, we were seeing a large population of people who were coming in with leaky heart valves because the valves had shortened and they had fused and they were no longer functioning to keep the blood from going backwards into one of the wrong chambers. And that is, normally the flow of blood is that the blood comes back from the body, it goes into the atrium, passes through the tricuspid valve into the ventricle. The right ventricle sends it off to the lungs, it comes back to the left atrium, goes through the mitral valve into the left ventricle and out the aortic valve to the rest of the body. But what happens is, particularly with the mitral valve and the aortic valve, when the valve starts to leak, it allows blood to go backwards either into the atrium or even worse back into the lungs. When you have blood that's backing up in the lungs, people develop respiratory symptoms. They feel short of breath, they have a funny cough, they simply can't get enough air.
So, like roughly, what percentage of what we call open heart surgery is valve surgery and what percentage is vessel surgery? Any idea? Can you estimate?
Well, yeah, most people's practices, coronary bypass surgery is about 70% of their surgery. I work for Vince Gaudiani with Pacific Coast Cardiac and Vascular, and he's such a phenomenal valve surgeon that 70% or even 80% of his surgery is valve surgery, and less is coronary bypass surgery.
I see.
So we're a major referral center for people with valve problems.
Now, Dr. Reed, you mentioned the aorta, how the left ventricle really squeezes or pumps and pushes the blood into the aorta, and from there the blood goes throughout the body to the brain, to the kidneys, etc.
Right.
Now, sometimes you're called to operate on the aorta itself, right, which is like the main pipe that delivers blood to the whole body.
Right.
Isn't that right? Now, why would the aorta ever need an operation?
Well, there's two main situations that happen, and the first one is what we call an aortic aneurysm, and that's where the elastic layer of the aorta has weakened and the aorta dilates up. And just like a balloon, the larger it gets, the greater risk it is at rupture. And so when somebody has an aortic aneurysm, usually it can present with, sometimes it can present with compression of a structure that's nearby, but most often it will present with rupture or perforation where it will allow blood to leak out. Obviously, that wouldn't be a good thing. And so when we find an aortic aneurysm, we want to try and fix it. Then an aortic aneurysm is not a good thing, but it's not usually an emergency operation. It's usually one of those things where we can get the person evaluated and get all their medical conditions taken care of so that we can do the surgery safely. But the far more serious one is what's called an aortic dissection. And that's where the lining of the aorta tears. It allows blood to partially get out of the aorta. And it increases the risk that they can have problems with strokes. The aorta can perforate. It can dissect backward and make the aortic valve fail, or it can affect the coronary arteries and cut off the flow of blood to the heart. And so that's truly what we call a surgical emergency. And as soon as we see those people, as soon as we make a diagnosis, we're trying to get them to the operating room as quickly as possible.
I see. You know, Dr. Reed, before we go on to the next topic, can you just briefly talk about pediatric heart surgery? You know, I mean, no, that's a subspecialty within itself. Certainly, we don't expect children to have vessel problems, but they do get into problems with the heart chambers, or sometimes the valves, sometimes the great vessels of the heart.
Right, right. The usual thing that there's two main issues with pediatric surgery. One is when we're in the uterus and we're not using our lungs, we have a mechanism in place that allows the blood to be diverted around the lungs so that it doesn't go through the lungs, since it's not being oxygenated. And what happens is when a baby is born and starts to cry and starts to breathe on its own, these little openings are supposed to close up. And occasionally they don't. Something like a patent ductus arteriosus or an atrial septal defect. If those don't close up, if the baby gets into trouble, then we need to go in and close them up, either by putting a clip on a patent ductus or going in and closing the connection between two chambers that doesn't belong there anymore. Nowadays, the cardiologists have become very effective with putting a device across an atrial septal defect so that we don't have to do that as much. Now, the other challenges with pediatric or congenital heart disease is that the embryology, which is how our bodies develop from single cells to the complex organisms that we are, there's a lot of potential for variation there. And so things can twist the wrong way, valves can malform or form incorrectly, blood vessels can grow in the wrong direction so that they come off the wrong chamber. Sometimes valves simply don't form, and so a chamber is literally a dead end. And those babies typically get into trouble very quickly, and they have to be operated on almost emergently. Mm-hmm. And that's the real challenge today, and that's the progress we've made in the last 10 years or so, that we can now save those babies.
Well, that's high pressure surgery, and I admire you guys from taking that on. Now, Dr. Reed, I could go on for hours talking about you. Before I bring up the next topic, I noticed when I looked at your resume, you were a flight surgeon in the United States Navy.
Yes,
you know,
sir.
So I was at Annapolis before I went back to college at University of Vermont and went to medical school. So I've done some time in Pensacola, and I see that you have too. I admire that. That's excellent, Dr. Reed. Dr. Reed, I want to tell you something about what I've noticed, and I'd like your feedback, because I want to know something about the mind of a cardiothoracic surgeon. Like, for example, when Dr. Sunday and I do a long microsurgical case, we'll go out to talk to the family afterward, and you know, many of them comment on, you guys must be so exhausted, physically exhausted, and the case went on for hours and hours. And I hear other people comment, well, you must have such great hands, you're a plastic surgeon. And I'm sure you hear that same thing too. They tell you must have great hands as a heart surgeon. And a lot of us are athletic. It's true. It takes a certain degree of physical prowess and athleticism. But to me, the difference is the level of concentration we require such a high level of concentration to do microsurgery or cardiac surgery. You operate on a kid, or when you open someone's chest and the beating heart's right there in front of them, I mean, you're not allowed to have a bad day. I mean, it's not the kind of thing where you can be happy-go-lucky about and say, well, I hope it works today. So have you ever noticed that when you get out of the operating room, it's really it's the level of concentration that has been required of you that can be exhausting? Have you ever noticed that?
I have, yeah. The typical thing is you'll walk out, or at least I will walk out, and I'll feel the strain in the back of my neck and my shoulders, and just the kind of overwhelming, and you just sort of slump and take a deep breath. And the thing that I've noticed is, and it's kind of funny, is that I've had people come in and carry out conversations with me that I have absolutely no memory of, and I don't hear what they're saying because I'm in the zone. And there was an old Kevin Costner movie where he's a pitcher in a baseball game, and he somehow makes the sound go off. And I have to say that until people came in and started talking to me, and somebody would say, you know, so-and-so was just here, he's talked to you. He was. And that's the thing that I've noticed, is that when I'm in that zone, I'm not aware of anything else other than what I'm doing. And
it's kind of an amazing level of concentration, don't you think?
right, it is.
Now the other thing that's fascinating to me is that when you're doing heart surgery and you're there on the table, roughly how many people are in the room with you?
Well, with an open heart operation, we'll have two surgeons at the table. There'll be a primary surgeon and an assistant. There may be an assistant taking vein, either a physician's assistant or it could be another surgeon. There is a scrub nurse who's handing up instruments. There may be a second nurse helping the person that's harvesting the vein. There's a cardiac anesthesiologist. And we also, on all our cases, we use a transesophageal echo probe. And so there's a technician who's running the probe. There's a gentleman who runs the heart-lung pump, what we call a perfusionist. And then, as often as not, there's another circulating nurse who's pulling drugs or pulling valves or getting different things ready for the next step in the operation.
Well, another thing I'm interested in, Dr. Reed, is, you know, we could consider the surgeon like the quarterback of the team. And I'm always interested in how another surgeon will keep everybody's attention and concentration on what you're doing, because people can get distracted or they get into their own job assignment, but really everybody in the room has to be helping to support what you're doing. Isn't that right?
Exactly right.
And so do you ever think about that? Like, how is it, are you conscious of getting everybody to concentrate on what you're doing?
Yeah, there are some times in a case where you can tell that people are being distracted or diverted, and you might raise your voice, or you might bring people back by saying, this is critical, we need some silence here. But in general, the sheer repetition of the operation, doing it over and over and over again, is such that people know when you come to the stressful part of the operation. And so I'm carrying on a dialogue with the perfusionist who's seated behind me. So it's usually a fairly loud statement, and it also tells people where we are in the operation, and they know just about what's needed next and how soon it'll be before we take the clamp off or come off.
Well, Dr. Reed, I must say, on a personal note, I really admire what you do. I have a lot of respect for you. You're one of the hardest working surgeons. I've trained in some pretty high-powered places, and you are a hard worker and a terrific guy, and I wish you the best.
David,
thanks so much for coming, and I'm honored you would come on the program.
Yeah. David, thank you very much.
Thanks for being here.
Yeah.
Well, that is another edition of Your Health Radio and Television program. I'm Dr. David Morwood. I am a board-certified plastic surgeon, and it's been great having you. Please keep in mind, if you have a comment or you want to suggest a guest or you have a question, email me at drmorwood.com. That's drmorwood. I'm happy to get your comments back. And my guest has been the illustrious Dr. William Reed, heart surgeon. Amazing.
Yeah, thank you.
Thanks so much for being here.
Thanks, David.
I think we're on for a little bit, so.